afternoon, everyone. Today I'm going to talk about the condition which is hyperthyroidism. So, what happens in hyperthyroidism? Sorry? Increase in thyroid hormones, right? So we'll just understand what like how the synthesis happens. Like, okay. So first we know that this hypothalamus will release a hormone called thyrotropin releasing hormone. So that will be circulated through a hypophyseal portal system, and it will come to this anterior pituitary gland. So then it will release this thyroid stimulating hormone. So that will come to the thyroid gland. Okay. So that will come to the thyroid gland mainly in this thyroid follicular cells. Okay. So that will act like that will bind to this thyroid stimulating hormone receptor. Okay. So that will it will bind to this thyroid stimulating hormone receptor. So then after that it will like send an intracellular message to this nucleus of the cell, and that will that will get activated. The gene will get activated in the nucleus, and that will produce a protein called thyroglobulin. Okay. So this thyroglobulin will pump out of this follicular cell of the thyroid in the like middle of the thyroid follicle. Like so think this whole thing is thyroid follicle cell. Okay. So and the surrounding cells are follicular cells, and in this thyroglobulin will be pumped into this region, middle of this thyroid cell. So then after that it will produce thyroglobulin, and it also like activate a enzyme called thyroid peroxidase. So what it will do, it to work, it needs a particular ion. You know what is the ion we like? It needs this thyroid gland, that is iodine. So this iodide from the blood circulation, it will be taken up to this cell through a sodium iodide symporter. Okay. So after that this TPO also converts from iodide to iodine. Okay. So this iodine, what this enzyme will do, it will combine this thyroglobulin and the iodine. Okay. So forms iodinated thyroglobulin. Okay. So after that it will take into this cell again, follicular cell again. So after that it will go through this proteolysis of the iodinated thyroglobulin, and then it will release this hormones like T3, T4. Okay. So done. Understood, right? After that what will happen, this we know this T4 is in abundant. Okay. So this T4 has to go like converted into T3 like active form. So after that this T4 will go into this nucleated cells. Okay, any nucleated cells. So after that it will convert into this T3. So this T3 will activate a gene in this in the cell that will like increase the protein production. This gene will increase the protein production and also increase this sodium potassium pump in the cell. So what it will do, this sodium potassium pump in cells, it will like pump out 3 sodium ions, and it will influx 2 potassium ion. In that process we need ATP, right, for this. So more the this pumps, more the ATPs will be used. So this body will it will try to generate more ATP because it requires ATP for this whole process. So what it will do to generate more ATP, the process called glycogenolysis and lipolysis will form. So metabolism of this will get increased. So that's why we see in hyperthyroidism there is increase in metabolic activity to get more ATP, right? So the byproduct we get from this all metabolic activity is carbon dioxide, water and heat. So more the metabolic activity, more the heat release will be there. So that's why there is increase in the body temperature, right? Okay, fine. Understood, right? This whole thing. So after that, the hormonal effect of T3 and T4 in various tissues, like the normal function of the T3, T4. So first is heart. In heart, what it will do, it will increase the sensitivity of adrenergic receptor. What adrenergic receptor will bind to? Yeah, like epinephrine, norepinephrine, right? After that, what it will do, like it will increase the contractility. So what will happen, it will increase the heart rate and increase the stroke volume because of the contractility. Fine. And coming to bones, it will maintain the osteoblast, the balance between the osteoblast and osteoclast. So, and in nervous system, it will increase the sympathetic nervous system, the flight and fight mode. And in skin, it will increase the blood flow in the dermal capillary, which is very important for this nail, hair, and growth of the nail hair. So, and also it acts on sebaceous and eccrine gland. Sebaceous, what it does? Oil production. And eccrine gland? Sweat production. So yeah, it will maintain the secretion from the skin. Okay. So the next is reproductive system. It will help in the development of reproductive system. Okay. And the next is it regulates the so this in reproductive system, it will help in the development of reproductive system and also regulates the sex hormone binding globulin levels. And in fibroblast, it will stimulate this fibroblast to produce a molecule that will help in the production of lots of connective tissues. And the second one is increase in the secretion of GAGs. GAGs is like glycose aminoglycans. That is a mucopolysaccharides. It is like what is it? Hydrogen water binding molecule. Okay, so it will hold lots of water, like it acts like a natural moisturizer for the skin because it holds water, right? It will like pool the water into this what cells, so it will maintain the hydration of the skin. And the next is skeletal muscle. In that, it will enhance the muscle contraction and also increase the regeneration and growth of the skeletal muscle. Okay, so now coming to causes of hyperthyroidism. Well, you understood, right, this one, the effects of the. And first is primary hyperthyroidism.
So in hyperthyroidism, so we have overactivity of organs.
Yes, of course. In this the functions will get increased. Yeah. And for coming to primary hyperthyroidism, like primary hyperthyroidism means there is a problem in this thyroid gland itself, not like in other parts, but in thyroid gland only. So the first cause will be Graves' disease, that is autoimmune, right? And the gene which is involved in this disease is HLA-B8 gene, and what it will do, it will produce THS receptor antibodies. So that will increase this what do you say, in this T3 T4 production. Okay. And the second one is toxic adenoma, that is in this thyroid, right? There will be one single nodule. Nodule is nothing but the clumps of follicular cell. Okay. And in toxic multinodular, you know, there will be more nodules in the thyroid. So that happens because of this THS, it's a thyroid stimulating hormone receptor mutation. Okay. And that will leads to the auto activation of thyroid stimulating hormone receptor. After auto activation, it will obviously go through all the process and production of the more T3 T4. And the secondary hyperthyroidism is having not in the thyroid gland but having problem in the pituitary. So a condition called pituitary adenoma, a tumor in the pituitary, that will release more THS levels. So THS level, more the production of the T3 T4. Okay. And next one is beta SCG. Beta SCG is beta human chorionic gonadotropins. It will actually in pregnant women, it actually gets increased. and also in hyperthyroidism. So you have to rule out the causes of hyperthyroidism. So you have to check for this also. If the patient is like a woman, and she came with some bleeding, uterine bleeding and pelvic pain and all, so you have to rule out this one. So what it does is it acts like THS, thyroid stimulating hormone, which will in THS, thyroid stimulating hormone, acts as a thyroid stimulating hormone that will increase the levels of the T3 T4 cells. Okay, so the tumor name is molar pregnancy and the choriocarcinoma. Okay, then the third one is destruction of thyroid gland, which is caused due to this production of antibodies like anti-TPO. TPO is like this, what is it? This one, thyroid peroxidase. Antibodies of that will increase in the production of this thyroid hormones. Okay, so that this production of this antibodies is mainly seen in this Hashimoto's. Okay, and there's postpartum thyroiditis. Postpartum, it happens in like within the 1 year of the postpartum. So it is a acute type of condition, and this Hashimoto's will be chronic. So the next one is drug induced, that like amiodarone, lithium and interferon alpha, that will injure the thyroid cells and leading to more production of the thyroid hormones. And the fifth one is pathogen induced, that is a virus which will obviously damage like injure the cells, and it will cause a increase in the thyroid hormones. And then the excessive iodine, this iodine will be more there, and it will get combined with the thyroglobulin and produce the more thyroid hormones. And the next one is exogenous thyroid hormone, that is if somebody is taking thyroid hormones from outside, like maybe he is hypothyroidism patient and all, so we have to check past medical history, past medical history. Okay, if we have to check if he is taking, he or she is taking any thyroid hormone from before because of some other medical condition and all, we have to check. And then coming to factitious hyperthyroidism, that is the patient is not having any hypothyroidism or and all, but he is taking the thyroid hormones because of some reason, or to lose weight, because it increases the metabolic activity, so it will lose weight. And the eighth one is ectopic thyroid hormone production, that is due to struma ovarii. So that is a kind of tumor in this fallopian tube and all. Not in fallopian, sorry, ovary. So this comprises of like more than 50% of this thyroid cells. So to be classified as a struma ovarii, it should have more than 50% of the thyroid cells, so that it acts like a thyroid gland and it will produce the thyroid hormones. Okay, so when there is an increase in the thyroid hormones, what it will do in heart, it will increase more heart rate and the stroke volume. And in bones, it in increase in this thyroid hormones, it will favors the osteoclast. So what it will do, it will more reabsorption of calcium will be there, and then osteoporosis. Okay, and next one is nervous system. In nervous system, it will increase the sympathetic nervous system. So what it will do in flight and fight mode, but like you will be confused, like should I fight or should I flight, like for that you'll have anxiety, what should I do? And because of anxiety, what will happen, we'll get like lack of sleep, insomnia. And also if you are in a lack of sleep, but you will like feel irritation and all. So irritation, lack of sleep, insomnia, and the this one, anxiety. Okay, and it also like acts on a muscle called this levator palpebrae superioris, that is present in this orbital part, it's a muscle. It will maintain this upper lid position. Okay, so more the T3 T4 cells, it will more contract the muscle, so it will pull the like this muscle. Okay, it will be like this. And then what? Skin. So in the skin, it will more blood flow will be there, so right, and more there's a growth of the hairs. Okay, growth of this nail, also there is the, because of the more growth of these nails, there's a condition called onycholysis, that is separation of this nail from the nail beds. Okay, and of course it acts on the sebaceous and eccrine gland. So what it will do, it will increase the production of sebum and increase the production of sweat. So that's why more sweating will be there in this type of patients. Okay, so next is reproductive system. It obviously it will develop the reproductive system and regulates the sex hormone binding globulin levels. So it will increase the regulation of the sex hormone binding globulin levels. So it will bind to this hormones called estrogen and testosterone in male. Okay, so more the binding of this hormones with this globulins, so there will be decrease in the levels of this estrogen and testosterone in the blood. So what it will happen in female, it will cause this infertility and irregular in menstrual cycle. Okay, and in male it will decrease the libido and will wait a minute. Yeah, it will decrease the sperm production and thereby gynecomastia. Okay, and next one is fibroblast. So in fibroblast, it will stimulate the fibroblast, and it will also this increase the secretion of gags, right? What gags will do, it will hold on to this water and all. So more the water inside the cell, there will be swelling of the cell and all. Okay, and next is skeletal muscle. In skeletal muscle, it will enhance the muscle contraction. More muscle contraction will be there, and also increase generation and growth. Because of this increase in this regeneration and growth, there will be kind of inflammation in this muscle. So that will cause myopathy, because of more thyroid hormones, it will be continuously growing and all. So because of that, this will cause a myopathy. And after that, coming to diagnosis. Okay, first is primary versus secondary hyperthyroidism. We know in primary on the gland, there will be problem in the gland, and the secondary will be problem in the pituitary. So in primary, T3 T4 will be more, and THS will be less. There is the negative feedback mechanism, right? So whenever there is an increase in thyroid hormone, that will send message to the pituitary, and it will say to stop the release of the thyroid stimulating hormone. So there will be less thyroid stimulating hormone. But what happens in secondary is there is a problem with the pituitary gland, right? So it won't stop releasing thyroid stimulating hormone. So there will increase more thyroid stimulating hormone. So in that, what we have to do, we have to obviously we'll see this thyroid function test, right? And also in this condition, in secondary, we have to do MRI, because there may be some tumor in the pituitary. So we have to go for this MRI, so that we can check if there is any tumor and all in the pituitary. So, and the next is the increase in the beta HCG. I told you, right? We have to check this beta HCG levels and free T4 levels, and we have to do this ultrasound to check if there is any tumor in the ovary. And next is thyroid nodules. Thyroid nodules in this toxic adenoma and this multinodular goiter. So in that we can palpate the nodule. Sometimes it will be fill, or we won't feel sometimes the nodules. In that condition, what we have to do, this radioactive iodine uptake scan and USG with Doppler. So in this radioactive uptake scan, what we'll do, we'll give radioactive iodine. So in that if there is a problem with the thyroid glands and all, and hyperthyroidism, they will need more iodine, right? More iodine to form this thyroid hormone. So more iodine uptake will be there. So in especially in Graves' disease, there will be diffuse uptake of this iodine. So that will become blackish color when you see the scan report, that will become black. And in focal, that is in toxic adenoma, that is focal, only one nodule will be there in thyroid. So only in focal reuptake will be there in toxic adenoma. And in this one, there is a multinodular goiter, there will be like in the more uptake of this. And antibodies, I told you, there will be production of the antibodies which causes the increase in the thyroid hormones. So what we have to check for antibodies: THS receptor antibodies, TPO, thyroid peroxidase antibodies, and thyroglobulin antibodies. And the next is serum thyroglobulin. In thyroiditis and struma ovarii, there will be more increase in the thyroglobulin production. So we have to check that. Coming to treatment, the first treatment is thioamides, that consist of methimazole, carbimazole, propyl thiouracil. So for methimazole, this drugs, it will inhibit the synthesis of thyroid hormones. It will also blocks the conversion of T4 to T3. So, and that the methimazole dose is 30 to 40 mg per oral daily, or in 2 divided dose for 6 to 8 weeks, or until we achieve euthyroid, means normal thyroid function. And maintenance dose will be 5 to 10 mg per day for 12 to 18 months. And for carbimazole, the dose is 20 to 60 mg per day, 2 to 3 divided dose until euthyroid. Okay. For propyl thiouracil, dose is 100 to 200 mg per oral in Q6 to Q8 hours. For 6 to 8 weeks. For maintenance dose is 50 to 150 mg per day for 12 to 8 months. So this actually causes this embryopathy. So we have to avoid in pregnant women and all. And in first trimester pregnancy, we have to avoid this drugs. And the next is radioactive iodine. This iodine 131. So what we do here is we give more iodine. So if okay. So what it does is, when we give more iodine, okay, more iodine influx will be there, and it will emit this beta rays or something like that. And what rays do, it will damage the cells, right? So it damages the cells, and it will decrease the production of this thyroid hormones later. And also it inhibits this TPO, thyroid peroxidase, which combines this thyroglobulin and iodine and forms this. Okay. So that dose is 80 to 100 millicuries millicuries per gram thyroid tissues, and average dose is approximately 10 millicuries per gram of the thyroid tissues. And the next one is iodide Lugol solution, 5 to 10 drops TID per oral, 10 to 14 days. The minimum effective dose is 6 mg per dose. This is also acts the same like this one. And next one is beta blocker, propranolol. Actually, this blocks the conversion of T4 to T3. I'm not sure, but it acts on that, and it will inhibits the conversion of T4 to T3. I thought that it blocks the beta adrenergic thing, and it will decrease this heart rate. But then when I study, it says that it inhibits the conversion of T4 to T3. So propranolol we will give for 10 to 40 mg per oral Q6 to control the heart rate less than 100 bpm beats per minute. And for next one is calcium channel blocker diltiazem for 120 mg per oral TID or 4 times a day. And for verapamil 80 to 120 mg per oral thrice a day or 4 times a day. So this one is given when the patient is intolerant to beta blocker, so they will prefer as calcium channel blocker. The next one is corticosteroids. Prednisone 50 to 140 mg per oral daily in divided doses, and 50 to 150 mg q per q6 hour for thyroid storm. Actually, this one is mainly given before giving this radioactive iodine, because this giving this radioactive iodine, what iodine will do, too much iodine will cause damage to the cells. So actually it where is that? This radioactive iodine is associated with the leakage of thyroid antigens, so that will lead to the increase in this antibodies, that is THSR antibodies, so that may initiate an eye injury, ophthalmopathy. So that's why we have to treat with like prophylaxis kind of, we have to treat with corticosteroids before giving this. And yeah, that much only.